Okay, so we start our clinic now. A very good afternoon and a very warm welcome to NITRD Central TB Division and National Task Force Difficult to Treat TB Clinic. On behalf of NITRD, it is my privilege to extend a heartfelt welcome to our esteemed DDG ma'am, Dr. Shobhini Rajan, the directors and teams from NIRT, NTI, STOs, directors of the STDCs, faculty members from medical colleges, district TV officers, and the team of presenters and experts, and all other distinguished participants, a very warm welcome. Excuse me, who's doing the screen sharing? Can you stop the screen? Yeah. And so it is my proud privilege to warmly welcome Dr. Rajendra Prasad sir, who has recently been awarded the prestigious Padma Shri. We extend our heartfelt congratulations and we are honored by your presence, sir. A very warm welcome. Also
Thank you,
today,
Nita. Thank you, everyone.
thank, so coming to introduction, I am Dr. Neeta Singla. I am Nodal Officer of DRTB Center at NITRD, and it is my honor to introduce the faculty of NITRD. On my right is Dr. Rupak Singla. He is consultant in the Department of TB and Respiratory Diseases. On my left is Dr. Saroj Meena. She is a senior pulmonologist at NITRD. And now it is my pleasure to welcome our director, Dr. Upasna Agrawal, who has a vast experience in TB as well as in internal medicine. So I request Dr. Upasna to give her introductory remarks. Dr. Upasna ma'am, over to you.
Hello.
Yeah, Dr. Upasna, we can hear you.
Yeah, I'm so sorry, ma'am. There is some internet problem in my room today.
Okay.
So I just then came out and did it from my phone. So welcome everyone and congratulations to to another session of Difficult to Treat TB Clinic, initiative of NITRD, CTD, and ECHO. And I congratulate Dr. Tanvi Chalke from Nashik, our postgraduate student who would be showing us an interesting case today. And I welcome our respected Professor Rajendra Prasad sir, Dr. Ashok Bhardwaj sir, Dr. Singla, and Dr. Komal Shah, the state expert. And I hope you have an excellent deliberation today. Thank you so much.
Thank you, Upasna ma'am, for your introductory remarks. Today, in our series of different states presenting, we have the case presentation from state of Maharashtra. Dr. Tanvi Chalke, who is the postgraduate student at Vasantrao Pawar Medical College and Research Center and Hospital, Nasik, will be presenting the case. Our state expert is Dr. Komal Shah, who is an associate professor in the same medical college. The next national expert for the day is Padma Shri awardee Professor Rajendra Prasad sir, who is the vice chair of NTF and who is the director medical education at ERA's Medical College, Lucknow. And our DT3C expert is Dr. Rupak Singla, who is consultant in Department of TB and Chest. So with this, we begin today's academic deliberation. Over to Dr. Tanvi for her presentation.
Myself, Dr. Tanvi Chalke. I'm a resident from Dr. Vasantra Pawar Medical College. I would like to address today our topic, difficult to treat TB. The case, hello, am I audible?
Yes, you are audible, Dr. Tanvi.
Yeah. So the case is a 33-year-old female, teacher by occupation, no non-comorbidities, and no past TB history, and no history of TB contact. For the first episode, the patient presented in December 2019.
Sorry to interrupt, Dr. Tanvi, just hold on. Your voice is not clear. Dr. Komal, can we request you if you can take over? Dr. Komal? Dr. Komal Shah? Dr. Komal Shah, we are not able to hear her clearly. Can you take over the case?
Yes, sure, ma'am. Sure.
Thank you.
Screen is shared by her.
Can we share the screen? If you want, we can share it, or if you want, you can share
I
whichever.
want to share because I'll be
Okay, so you
able
can
to
share your
handle well.
screen.
Screen share. Huh. Is my screen visible?
No, it's not visible. Like means screen sharing has started, but we can't see the PPT.
Can you see now,
Yeah,
ma'am?
yeah, it's clear now.
Yeah. So good afternoon, everyone. I'm Dr. Komal Shah, Associate Professor from the Department of Respiratory Medicine. And the case was supposed to be shared by our resident, but unfortunately her net is not working. So I'll be sharing the case. So the patient is a 33-year-old female, a teacher, with no comorbidities or no past TB contact. This was the first episode, and first she presented to us in with complaints of fever, cough with expectoration and weight loss for 1 month. This was in December 2019. This was in a private setup where she presented. So there, on examination and investigations, they found out that she had cervical lymphadenopathy as well as left lower zone consolidation. So if we see here in the CT scan, it is clearly shown that there were bilateral bulky hilar and mediastinal lymphadenopathy with encasement of adjacent bronchovascular structures, and it was associated with perihilar and lower lobe parenchymal opacities, which was suggestive of post-obstructive consolidation and ground glass changes. This was in December 2019. So they went ahead with cervical lymph node biopsy, and histopathology was suggestive of granulomatous lymphadenitis with cold abscess of mycobacterial etiology. Gene expert was suggestive of Mycobacterium tuberculosis, and rifampicin resistance was not detected. So patient was started on DSTB treatment on 16th of January 2020. Further, after a while, when they got the culture reports, it showed resistance to isoniazid, pyrazinamide, ethionamide, and ofloxacin. So based on this, the treatment was changed at the private center, and she was started from February 2020 on this following regimen, which included 4 months of kanamycin, rifampicin, ethambutol, moxifloxacin, and terazidoline. Then next 4 months, they removed kanamycin and continue with the rifampicin, ethambutol, moxifloxacin, and terazidoline. Then again for next 4 months, she continued her on rifampicin, ethambutol, and moxifloxacin. And last 3 months, she was given ethambutol and moxifloxacin. She was followed up very much regularly. The patient has all the records, all the data with her, and repeated X-rays and were done. Now, after this, the patient improved clinically, radiologically. There was no cervical lymphadenopathy. There was radiological resolution as well with healed fibrotic bands and traction bronchiectasis. So on basis of this, the treatment was stopped in April 2021. So after that, patient was declared cured and she was home. Hello, can you hear me clearly?
Yeah, very clear, Dr.
Yeah. So after 2 months of the first treatment, after stopping the treatment, she presented again with fever, cough, and loss of weight for 1 month. So practically speaking, she was fine for 1 month at home, and then she started having these complaints. And this was the first X-ray taken after 2 months. So this was in June. And I don't find any major problems in the X-ray. However, she had cough and expectoration. So sputum was sent and it showed again MTB detected. Again, it was rifampicin sensitive. This time they had done line probe assay. Again, this was as the same private setup where she was treated for the first time. And this time it was sent for LPA. And LPA again suggestive of isoniazid resistant and rifampicin sensitive. In this time, LPA was suggestive of fluoroquinolone sensitive and second line injectables also sensitive. So based on this, at a private center, she was started on rifampicin, ethambutol, moxifloxacin, and kanamycin. Then somewhere INH was also added. Patient improved clinically and radiologically, and follow-up cultures were done on repeated intervals, which were negative. So after that, when patient improved clinically, radiologically, cultures were also negative. At the end of 15 months, the treatment was stopped. That is 20th September 2022. After that, for 2.5 years, patient was asymptomatic.
Komal, can I
Yes,
stop
sir.
for a moment because I have to leave in between. These subsequent cultures were done from lymph node or from which sample?
No, sir, from the sputum. This time she did not have lymphadenopathy.
Okay. So from the
second
sputum,
episode
the
was only she had complaints. Her X-ray and CT were not showing anything, and sputum was positive. So the third episode, which is the present episode, patient presented after 2.5 years of second episode. All this while she was fine. She was working as a teacher. She was going on a regular work. So now she presented with swelling and pain in neck region for 20 days. And on examination, they found that it was cervical lymphadenopathy. So again, biopsy was done.
What was the size of lymph node, Komal, to begin with?
The size, sir, we don't have the report of
Yeah,
the
you
size
don't
of
have.
the lymph node. Because it was again done at private center only.
In one of the report, I went and find that there was a cold abscess-like picture. So
Yes,
we don't know. And the third and the last question: these cultures and LPAs, as she was treated by a private sector, so these were done from the reliable lab or from the government lab, some IRL.
So they were done at the Metropolis lab.
Acha, at Metropolis lab. Okay.
Yes,
Okay. Go ahead. I'm sorry to interrupt you.
No problem. So histopathology report on 9th of January 2025 was suggestive of necrotizing granulomatosis. Now, gene expert was again sent and it was again MTB detected. This time it was rifampicin indeterminate. So patient was not started on any antibiotic till the DST reports came, and she was sent to us in March 2025 when again the DST was showing isoniazid resistance. So this was the third episode where she was showing isoniazid resistant. Now this time the resistant pattern is as same as the first episode, which is isoniazid resistant, pyrazinamide resistance, and ethionamide resistance, except this time fluoroquinolone is sensitive. Bidaquilin was also done, which was sensitive. So this was the third episode with which she came to us. So we started her on all oral longer regimen in March 2025. So we started her on bedaquiline, linezolid, levofloxacin, cycloserine, and clofazimine. She started tolerating it well. However, she presented again with swelling in all over the body, joint pain, and difficulty in getting up since May 2025. So March we started and we started the treatment.
Is currently busy.
And in May she presented with this complaint. So she came to us in June, but she started having complaints since May. She also started having suicidal thoughts after for 15 days of starting swelling all over the body. So she came to us in June, and then we did all the investigations, and on CBC we found that she had pancytopenia. So in June, the treatment was modified. Psychology counseling was done. So because of the suicidal tendencies, cycloserine was stopped. Linezolid we had decreased to 300 because it was showing pancytopenia as well as All other side effects like swelling all over the body and difficulty in getting up. Levofloxacin was changed to moxifloxacin.
May I interrupt, Komal? May I talk to Dr. Rupak?
Yes, sir.
Yes, sir.
Rupak, I'm sorry, but I'll leave in between because they are calling me in the function.
Yes, sir.
So my only say is that I don't know what is the current size of lymph node. If it is there, some surgical intervention, my feeling, because we have seen many such type of lymph node TV. And the another point I always say is that the labs vary in their reports, and this was also seen in this patient. And the third point I wanted to share here as the why the INH resistance regimen was not started. It means the somewhere, as an NTF vice chair, my concern is somewhere there is a lack of education among the private sector, because now we have a guideline for INH resistance tuberculosis. So I don't see that any time that guideline was adhered. My only say before I should leave that we need more and more education. Our NTF chair is also sitting, and so I always say this that the education, although we are doing a lot, but still it requires more and more education, especially to the private sector. If you are treating such type of patients, you should treat like this. Thank you very much. I'm sorry that I have to leave. There's some felicitation from the Lucknow University, which my alma mater. So I'm leaving. Thank you very much.
So congratulations again for your permission.
Thank you, madam. Thank you.
Thank you, sir. Just one line since you have raised the issue. You see, gradually we are noticing the participation of medical colleges in this clinic is very, very minimal. So, I mean, so you are there, then NTF chair is also there. We request that more and more faculty from medical colleges may attend this. So that's my request.
Yes, your point is very well taken. Point is very well taken. Thank you.
Thank you, sir.
Yeah, sorry, Dr. Komal, you may continue, please.
Yeah. So from June again we changed the regime. We started we reduced.
इसको बंद ही कर दें, अब आप नहीं ज्वाइन करें. एक मिनट.
Can we go ahead?
Yes, Dr. Komal.
Yeah. So linezolid was reduced to 300 milligrams. Cycloserine was stopped in view of suicidal tendencies. Levofloxacin was changed to moxifloxacin, and DLM was added because we were left with only 3 medicines. So from June, we had bidaquilin, but because linezolid was reduced, we added DLM also. So from June, we had BDQ, linezolid 300, moxifloxacin, clofazimine, and DLM. Now, BDQ was stopped after 6 months of treatment as per the programmatic guidelines in September 2025. Now, again, the patient is presenting to us this January with complaints of facial puffiness and peripheral edema since 1 month. We invested her further, and her CBC was again showing WBC counts of 3000. The proteins were fine. The create was 0.72. So we repeated the USG net to check whether it was progressing or not. But the lymph node size were almost the same. There was no new lymph nodes. And we found the right level 3 and level 4 necrotic nodes and right level 1B non-necrotic lymph node. Clinically, she was fine. She was gaining weight, no fever, nothing. But she had this peripheral edema, facial puffiness since 1 month. So linezolid was already 300. So we had to stop it because this was the 3rd or 4th episode of pancytopenia she had. And she also had peripheral edema. And now we are left with DLM, moxi, clofazimine that we are planning to continue for the rest of the 9 months. So to summarize, the first time patient presented in December 2019 with cervical and mediastinal lymph nodes plus pulmonary involvement. And that time, cultures were suggested, cervical lymph node biopsy culture was suggestive of resistance to INH, pyrazinamide, and ethionamide, plus ofloxacin. I've forgotten to mention here ofloxacin. So she was treated for 15 months with kanamycin, rifampicin, ethambutol, moxifloxacin, and terazidone in a decreasing trend. Just after 2 months of completing first treatment, she again presents with pulmonary TB this time, and this time it was resistant to INH. Now this time only LPA was done, so we don't know the status of PZA and ethionamide. However, it was sensitive to moxifloxacin in second line LPA. So this time she was treated with rifampicin, ethambutol, moxifloxacin, and kanamycin, which was given for 4 months, and total 15 months of treatment was continued. After 2.5 years of completing this treatment, now she presents to us, that is third episode, in March 2025 with cervical lymphadenopathy. Again, resistant to this biopsy was done from cervical lymph node, and cultures were suggestive of INH, pyrazinamide, and ethambutol resistance. So she was started on all oral longer regime. Within 2 months of starting the treatment, she had ADR for which linezolid was reduced to 300 and cycloserine was stopped. So from June to Jan, she was on bedaquiline, linezolid 300, moxifloxacin, clofazimine, and dilaminid. And from February 2026 onwards, she is on DLM, Moxi, and clofazimine in view of again ADR, that is peripheral edema, and decrease in WBC counts. So this was the case.
Thank you, Dr. Komal. So are there any questions regarding the history, presentation, or investigations?
Ma'am, I had prepared one more PPT about the like questions and all. Should I share that?
Yeah, so we wanted to know what are your issues, like what are the current issues that you want to discuss?
Yeah.
Yeah.
So new share I should do.
Yeah, because you had raised some questions. Can you display them?
Yes. So I made a small presentation. I thought that Tanvi will be presenting this. That's why.
We can read her question.
She will share.
मैं मेरठ से बोल रहा हूँ
जी सर.
मॉक्सीफ्लॉक्स इनको हाई डोज में दी गई थी या लोअर में?
No, my 400 milligram was given.
And what was the weight of the patient?
So 1 second.
Weight of the patient.
Weight of the patient is around 60 kg.
You have the older one.
I think, sir, high dose moxiflox is more effective in all or longer, in my opinion. Low dose is not working as such. Rupak sir will say some about this.
Yeah, your question is whether high dose moxi was given or not.
Sir.
As a part of the all or longer regime. What's your question, sir? Can you repeat?
Yes, sir.
Can you repeat the question? I feel your question is, can you, I mean, in this case, once you started the all or longer regime, high dose moxi should have been given. Is that your question?
No, sir, that is not my question.
No, Rajkumar.
Sir, this is my question. It should be given in low dose or high dose?
Actually, with moxi, there are two only: normal dose and high dose. And in the all or longer regime, we go to high dose only when we have documented resistance to fluoroquinolone and documented sensitivity to high dose moxi by looking at the genotypic data. So that is the indication.
Thank you, sir.
Thank you.
So, should I start my presentation, sir?
Yes, Dr. Komal.
Yeah. So again, I had just written something about the beef test study. So she's just to summarize, she is a 33-year-old immunocompetent female. She had 3 episodes of TB over last 5 years and has persistent isoniazid resistance all in 3 episodes. Rifampicin has been consistently sensitive. And final episode where she presented was isolated cervical nodal TB. She also has significant ADR limiting the regimen potency. So whether this is relapse or reinfection or persistence. So to answer that, we do not have any molecular samples. We do not have whole genome sequencing comparison available. So this could be possible persistent mediastinal focus. It could be possible reinfection as well, because there was high exposure risk, especially between the third and the second episode where she was exposed as a teacher. But her the sensitivity pattern has been same in all the three episodes. So possible persistent mediastinal or cervical focus could be one reason, and possibly due to suboptimal effective drug exposure.
I'm
So why recurrent nodal TB?
Dr. Diwan here because Dr. Rajendra Prasad had also talked about the surgical, because its neck is such an accessible area and there's so much of complexity. I think once as much debulking of the lymph node size as possible under general anesthesia and giving all these samples for this thing, whatever research that you want to do on the sample of molecular sensitivity is a good idea. That is my suggestion. Of course, Dr. Rupak will summarize
Yes, sir.
the entire thing, which is in a more, detailed manner about the drugs. Because what I find, as Dr. Rajendra Prasad said, the drugs have been given earlier in a slightly haphazard manner. Now, of course, you are coming down to a systematic approach to it. But in addition, this debulking and subjecting whatever specimen you get to analysis is an idea which is worth considering. Over. Thank you.
Yes, sir, definitely. And one more important thing in her case is we are limiting the regime potency by because of the ADR. With linezolid, she experienced pancytopenia, peripheral neuropathy, even peripheral edema. With cycloserine, she had suicidal tendencies. We had stopped BDQ at 6 months, so we did not have that. Singla sir, you wanted me to say something about peripheral edema in this patient. So whenever they have patients of with peripheral edema, we must first make a differential diagnosis, whether it is secondary to drug-induced or due to systemic complications like hypoalbuminemia, renal failure, cardiac failure, or it is local thing like DVT. So to confirm the diagnosis, we would obviously work up. We'll do CBC, serum albumin, ECG, echo, Doppler, USG, etc. So in this patient, we did the same, and we found out that albumin was not too low to have peripheral edema. So now, how to treat these patients? If there is edema which persists, then we should stop linezolid till the patient becomes normal, and then we can reduce the dose to 300. If in spite of giving the dose, we can also add low dose diuretics along with that. And if in spite of doing all this, if patient is still persistently having peripheral edema, we can just stop the treatment. So now the questions that I have in my mind, that immunocompetent paradox. So this patient was totally immunocompetent. She did not have HIV, she did not have diabetes, and no as such past medical histories. So in this young, healthy, immunocompetent patient having 3 repeated episodes within 5 years, should we look for any other immunodeficiency in this kind of patient? Second question is the sensitivity dilemma. What I am trying to say is that in first culture, the Oflox was resistant. However, in third culture, it was sensitive, and in second line probe assay also fluoroquinolones were sensitive. So could there be mixed population? Could there still be moxiflox resistance, but we are still giving moxifloxacin? How should we go ahead with this 3 different culture reports as far as moxifloxacin is concerned? Third is regimen strengthening. What I'm trying to say is that for last 6 months, she giving only that will be rofazine and moxifloxacin. That too, we are not sure whether it is sensitive or not. So, is this enough for this patient who's appearing third time? Should we increase the duration? Like last 6 months, we need to do it for last 9 months, or should we add BDQ at this point to strengthen the regimen? Is it strong enough? I also wanted to know about whole genome sequencing, if there is any role for that, because we don't know whether this is relapse or reinfection. So can somewhere whole genome sequencing help? And I understand that TDM is done when there is failure. However, this patient always improved clinically and then again got infected. So TDM may not be a picture here, but still, is there any role of TDM here, therapeutic drug monitoring? Thank you.
Thank you, Dr. Komal. We have some questions on the chat box. Can you take them, Dr. Suresh?
Yes, ma'am. So the first question is whether it was necessary to stop linezolid or not. I think it was needed to be stopped because of the lots of areas the patient was having due to the linezolid. Another question in the chat box is during the second course of the treatment, the patient relapsed within 1 month. So the treatment was stopped in the month of April and patient was presented again in June. So there was only gap of 2 months. So the question is that case CBNet can remain positive for a long time even after stopping the treatment. So is it significant to take the patient or not?
And maybe because next time, the second time you said it's pulmonary. So do you have any X-rays?
Yes, yes, ma'am. I've shown the X-ray in my PPT.
No.
However, it did not show any significant abnormality, and we do not have any CT scan of that time.
And you see, regarding this within 2 months, what we see that your patient has completed the treatment, we declare the patient as cured, and you find within 1 month, 2 month, patient comes up again with symptoms and so here it is actually failure of treatment. It is very, very uncommon that within 1 month patient will relapse. The definition or the presentation of relapse is patient completes the full treatment, becomes asymptomatic or minimum symptoms, X-ray shows improvement, and then remains asymptomatic with culture negativity for some time, maybe a few months, and then comes up again. These kind of patients who present within say 2 months or so, usually they are failures who have been wrongly labeled as cures. And secondly, as rightly pointed out, the positivity on gene expert should not be taken as a case of relapse. So we have to investigate the patient again, whether in the earlier episode patient was responding to treatment, achieving culture negativity or not, and now this is really relapse, or he had failed to the treatment and now presenting again within between one or two samples being negative. So we should be very clear about these aspects. Thank you.
So there's one more question in the chat box. Could it be a case of MSMT, Mendelian susceptibility for mycobacterium disease?
Yes, I will come to that. There is a possibility we will come to that.
Sure. So there's another question from Dr. Amitesh. He's asking, can we add rifampicin to this regimen just to strengthen the regimen? And patient was always sensitive to rifampicin.
Okay, we'll come to this point also. Very important point Dr. Amitesh has raised. We will discuss this point also once we discuss the entire case.
STDC West Bengal has raised hand. Yes, sir.
Good afternoon, ma'am and sir. Sir, actually, the common finding found in the 3 episodes is the pyrazinamide resistance. Now, it could be one of the remote possibilities because we know that pyrazinamide is a drug which is for persisters. Now, in every first, second, third case, pyrazinamide came to be resistant. So we can say that might be there is the persisters still there in the patient, and that in the every episode that recurred. And so we can say that even if there is a pyrazinamide resistance in baseline drug sensitivity or drug resistance test, we can say that this case might recur subsequent 3 or 5 years. And that actually happened in here also. You see that in 3 episodes, pyrazinamide came resistance. You can opine, ma'am, and sir, further better.
Yes, sir. I think definitely you raised a very important point, and Dr. Mitesh also. We have, as far as sterilizing drugs are concerned, we have pyrazinamide, we have rifampicin. And this patient unfortunately never received either rifampicin or pyrazinamide being declared as resistant in all the 3 episodes. So that could have been one of the reasons that patient is relapsing again and again. So we need to keep in mind that absence of these two drugs could have been one of the possibility of having recurrence. So very well point taken by you as well as Dr. Mitesh.
Do we have some predictable factors in such cases where we can predict who are the candidates for this kind of relapses?
Yeah, we'll come to that.
Okay. That's okay.
And let us discuss the case in totality. So, if you see this case in the first episode in December 2019, she had mediastinal lymph node and lung tuberculosis, which was resistance to H, Z, ethonamide, and fluoroquinolone. Patient received 15 months of treatment, which consisted of rifampicin, ethambutol, moxifloxacin, terazoline, and various combinations. And you see again treating such cases with different combination of drugs which are not scientifically correct, and that too for 15 months. We need to educate our colleagues in the private sector that how these cases should be treated. They can even take the opinion or refer the cases to the government sector so that adequate DST can be done and the regimen can be modified accordingly. And also we have always a doubt about the DST by the private laboratories. So we need to see that also, that from the beginning, why should a patient present with resistance to INH, pyrazinamide, ethonamide, and fluoroquinolone? So we need to see that also. Yes, among the MDR-TB cases in the country, roughly 30% may be resistant to pyrazinamide. But upfront at the baseline was never received the treatment. Having pyrazinamide, ethonamide, H and FQ resistance is not that common. FQ resistance in our country maybe around 20-25% is there. So that has to be kept in mind among the MDR-TB patients. Now the second episode occurred in June 2021, pulmonary tuberculosis, and was found to be INH and rifampicin sensitive. And patient received in various combinations rifampicin, ethambutol, moxifloxacin, and kanamycin. Patient improved, and again, patient had taken this for 15 months. And again, as we could see, initially 4 or 5 drugs, then 4 drugs, then 3 drugs like that, which is not a way of treating a case of tuberculosis. Injections, yes, we stop in the beginning. And then after that, we need to maintain the rest of the drugs. We need to follow the case clinically, radiologically, and by the cultures. Unless we do that, we cannot step down the treatment or step up the treatment. And adequate number of effective drugs have to be there. Treating a case for 15 months with irrational combinations, they are the cases where patients are very likely to have resistance to 1, 2, or 3 drugs. Now, the third episode was in January 2025, around say 13-14 months back, when she had cervical lymph node, and the FNAC showed CBNet MTB present, but rifampicin indeterminate. And it was never repeated. You see, it should have been repeated once we say rifampicin is indeterminate in a patient who has taken rifampicin. It should always be repeated. We should not be satisfied with one report only. And we don't even know whether like even the LPA can be done in case MTB is present there or the smear was positive. Then the DST showed INH, pyrazinamide, ethonamide resistance, and patient was sensitive to rifampicin, ethambutol, fluoroquinolone, injectables, bedaquiline, linezolid, and clofazimine. So this was extended DST done. And in these cases, whenever there is a doubt, one can repeat the DST also, especially from the government sector. Because now we are taking therapeutic decisions based on the DSTs and the past history of ATT. So in March, patient was based on the entire thing in March. So again, there is a gap of 2 months between the presentation and the laboratory reports. and starting of the ATT. In March, patient was started on all or longer regime consisting of bedaquiline, levofloxacin, linezolid, clofazimine, and cycloserine, which is the conventional the all or longer regime. In May 25, that is within 2 months of starting this, patient had swelling all over the body, suicidal thoughts, and pancytopenia. So, in view of these three side effects, the levofloxacin was replaced by moxifloxacin, linezolid was reduced to 300 mg, bedaquiline was continued, clofazimine was continued, cycloserine was stopped because of the suicidal thoughts, and delamanid was added to make a combination of 5 drugs. Then in September, bedaquiline was stopped in view of the fact that patient had completed 6 months. You see, again here we need to see whether to stop or not, or whether to extend the duration, looking at the what other drugs we have in hand. But since here we had this after stopping bedaquiline, still we had 4 drugs. Maybe that was the reason that bedaquiline was stopped at 6 months. But it should be strictly followed by culture negativity of lung TB or lymph node TB whenever we take a call to stop the bedaquiline at 6 months. Then in September it was stopped. On 1st of Feb 26, linezolid was stopped due to the adverse drug reactions. So now after that, patient is on 3 drugs: delamanid, moxifloxacin, and clofazimine. And earlier also, see, when we could not give linezolid full dose of 600 milligram, then the efficacy of regime can be compromised. So from that point of view, also we need to see whether to continue bedaquiline or not. Anyway, from 1st of February onwards, now the patient is on 3 drugs, that is delamanid, moxifloxacin, and clofazimine, and the treating site has decided to continue this for next 9 months. So now with this background, what were the questions which were posed to us when the case was sent? First was BPLM a better choice in this patient in place of all or longer regimen? I would like to know the opinion of the House. What do they feel about this? Anyone in the people who are attending would like to answer this? Anyone, please? You see, in this case, yes, that could have been, should have been considered, because in the beginning, that is about the January 25 onwards, not now. At that time, she has not taken bedaquiline. So, and there was no contraindication. And even if after starting the treatment, patient has had this adverse reaction, which we may not be knowing at that time, there is a possibility of coming down of linezolid dose to 300 milligram, but only after 9 weeks of treatment. So in the BPLM, we start the regime with the usual dosages for all the drugs. It is not permitted to reduce the dose of linezolid to 300 milligram in the first 9 weeks. It is not permitted to stop any of the drugs other than moxifloxacin permanently throughout the regime. So only change which we can make is reduce linezolid to 300 milligrams after 9 weeks, and in that case we have to extend the treatment to 9 months. So from that point of view, the BPLM could have been chosen in January 25. Now the next question is very important: is can delamanid be continued till the end of treatment? That is now 15 months total. The answer is yes, if required. If required, and we feel the continuation phase may not be adequate if we have to stop the delamanid, like in this case, patient is having only 3 drugs in hand. So in case we are not having this, and after in these cases to have the strength of the regime being maintained, one can continue delamanid till the end of therapy, and that is very commonly required in such cases who have this kind of the DST patterns. Now the third question was, can bedaquiline be reintroduced now if any of the above drugs need to be stopped? Yes, it can be, but generally it is avoided. Generally it is avoided that once bedaquiline has been stopped after 6 months to start again. And in this case, as of now, it is not required. You see, the only cases where we can think of bedaquiline response is that you are giving a bedaquiline containing regime. And in the first 6 months, you find clinically, radiologically, and pathologically patient has responded well. And after 2, 3, 4 months, now you find the patient is positive again, typical like a flow with the fallen rise phenomena. In those cases, we presume that in the first 6 months, patient was sensitive to bedaquiline. So if we are cornered, if we are not able to make a regime with good number of drugs, we may consider giving bedaquiline again, but usually it is to be avoided. Now, the next question was, any additional treatment to combat the failure, the future relapses? Yes, you see, in case now the patient is with us, we must ensure that patient is on appropriate treatment, the appropriate dosages, and completes the full duration of treatment. Otherwise, patient is likely to relapse again. And as was discussed by Dr. Komal also, in this case, you see now, fortunately, in some of the places, we have therapeutic drug monitoring for the second line drugs. Like in our institute, we have bedaquiline, denamnate, the quinolones. In these cases, we have including the linezolid also. We have the facilities for the TDM for second line drugs because we are not sure. She is on second line drugs. We are not sure whether she absorbed first line drugs or not, and whether she will be absorbing the second line drugs or not. And we can do TDM only to second line drugs because currently she is on second line drugs. So currently, as per the current dosages, we need to do the TDM following the proper protocol. That is, patient should take these medicines at the same time of the day, usually say 8 a.m. in the morning, for about 7-10 days. And next day, patient reports. The medicines are given in front of the healthcare worker, and we draw the blood after 2 hours, 4 and 6 hours. And then why 4 and 6 hours is to look for the delayed absorption. Sometimes we find 2-hour sample is showing low levels, but at 4 months or 6 months, the levels of the drugs are normal. So we call it as delayed absorption. So they are not treated as malabsorption for the drugs. And in those cases, the same dosages can be given. And after this, in this case also, we need to do the, depending on the case, whether pulmonary TB or lymph node TB, we need to document the repeated culture negativity to look for any relapses in between. Next. So as very important is what could have been the reason for repeated relapses in this young healthy patient. You see, if you look at the in general, the poor adherence which normally we miss, high bacterial load like in patient with cavity diseases, inadequate treatment regime, missed drug resistance, that is patient has resistance but that is missed by the laboratory or by the treating physician, poor absorption, so here we need to do the TDM. Then comorbid conditions like HIV, diabetes, malnutrition, and immunosuppression, they are known to be associated with repeated relapses. And also India being the high endemic country, reinfections are not uncommon, and we have seen cases who were pre-XDR or XDR, and they were treated with the second line drugs, they became all right, and after 1 or 2 years, they presented again with symptoms and fresh X-ray findings and were found to be drug sensitive. We gave drug sensitive TB treatment and they responded. So in endemic countries, even fresh infection can also be a cause of relapses. Next. Now, as somebody raised also, there is an entity called MSMD, Mendelian Susceptibility to Mycobacterial Diseases. So here this is a group of rare genetic disorders where there is impaired interferon gamma and IL-12 pathway signaling, which can lead to vulnerability to the infection. And you see, very interesting is they are vulnerable to Mycobacterium tuberculosis, NTMs, disseminated infection after the BCG vaccination. So in these cases, if you should document MSMD, BCG vaccine is not to be given, and to salmonella infection. So this is known. If somebody has this MSMD, then these are the infections which are there. And the treatment of MSMD is the prolonged the antimicrobacterial therapy, and the recombinant interferon gamma therapy can be used in some of the isolated effects, and hematopoietic stem cell transplant, but none of them is available in our country. But we should know this that entity exists, so that whenever we are working with the patients, we need to look at this also. And next. And very interesting again is there is this parameter called CD38, and it has been said that it has 100% sensitivity and quite a high, that is 78% specificity for detecting TB recurrence at month 9 or 12 post-treatment initiation. Again, this is not routinely available, but for knowledge sake, we should know that these are the things which are there. So you see, to sum up, basically, whenever we have this kind of patient who are relapsing, first we should look at our regime, our dosages, the compliance of the patient, whether patient is absorbing the drugs or not, and any associated of this comorbid condition. Malnutrition, very common in our country. Immune suppression, sometimes it is there and we miss it. Same thing with HIV. You know, in HIV, it is known that they absorb the drugs so poorly that if the CD4 count is less than 50, there are reports they found rifampicin level to be 0. So which no, some unless you suspect, you will not be even checking for it. So HIV is a known cause of poor absorption of the drugs. We need to see and follow them up with the CD4 count and adequate anti-HIV treatment so that their malabsorption is taken care of. And these are the interventions which we should see. I mean, they are the common interventions. And whenever we have patient with the cavity disease, these are the cases where chances of bacterial load being in millions is very high. And sometimes they are hidden here and there in the cavities, and the cavities are not completely sterilized. So there also these hidden bacteria may be a cause of the relapses in such cases. And regarding the surgical part, usually what we practice is we give the ATD adequately. Once we believe that the lesion has become sterilized, then in that case, if required, we resort to the surgical intervention. But usually we are not resorting to. We have very strong surgical team headed by Dr. Diwan. But whenever we discuss the case with him, usually he says first you try the chemotherapy first, and if required, sometimes it is for cosmetic reasons also in females, then the surgical debulking is done. Or you're doing chemotherapy and patient is not responding and they're increasing in size, not as a part of iris, even the later part of the treatment, then surgical options they can be considered. Or in cases when you find the lymph nodes are compressing on the airway, that could be another indication of thinking about the surgical removal of the glands. Then somebody had raised the issue of the WGS in this type of cases. You see, basically WGS tells us about the DST to all the 13 drugs in a sort of taking lesser time. But in these cases, I don't know the role of this, how much it is. Secondly, what we are observing is that the catalog which is available from WHO for the WGS is incomplete. There are many genes which may be seen in India, like maybe whether lineage 1, 3, or 4, whatever it is. And the genes which are responsible for drug resistance in India may not be adequately covered by the existing WHO catalog. And I'm told that it is being revised. Our Indian researchers have given their data so that the WHO catalog can be updated and some of these genes which could have been otherwise missed, they can also be incorporated. So in this particular case, at this juncture when all these medicines have been given, I find the role of WGS will be very, very limited. So I need to say about the mention about these things, and I hope the few of the things are clear. Thank you so much.
Sir, I have one question.
Yes.
We usually consider MSMD in pediatric population. We usually look for it. So does it also have a significance in adults too?
It may be. We do not know. Usually it is seen in children, but it may be seen in adults also. Usually it is a disease which is diagnosed in children.
Thank you.
Are there any other questions? Yeah, Dr. Komal, I hope your queries are taken care.
Sir, I have one question about moxifloxacin resistance. So first Oflox was resistant, then in LPA it came as sensitive in second episode, and third in culture it came as sensitive. So is it still sensitive or mixed population, what we should consider?
Yes, it is difficult to say whether it is a mixed population or not, because this question of heteroresistance always comes up. So in these cases, you see better in case somebody has taken quinolones earlier, and one report says resistance, other report says sensitive. We should take it. We should take it with a pinch of salt. And even if we are giving, we should not count this drug as an effective drug. And regarding this, somebody had raised the question of high dose moxi versus normal moxi. You see, in case you find that the in GAIRE 3B, 3C, and 3D, all the mutations are absent, only then we believe that high dose moxi will be effective. If any one of them, that is GAIRE 3B or 3C or 3D mutations are there, even high dose moxi will not be. So we need to see the LPA result accordingly. We can ask the microbiologist whether these genes are there or not, and then take a call for the high dose moxi. And in our country, the quinolone resistance among MDR is fairly high, to the tune of 20 to 25% among MDRs. So again, indicating that we, in such cases, we may not count it as an effective drug.
I think STDC West Bengal. Sir, you have a question?
Actually, ma'am, I have some comment. Uh, in case of heteroresistance, to do a LCDST or indirect LPA, you need a pure culture. Now, if it is a population, heteroresistance population, then after midget culture, you will get the drug resistance strain will be a slow grower, where the drug sensitive strain are fast growers. So it means that they will grow within a span of say 11 or 12 days, and drug resistant strain will go later. So in midget liquid culture, drug sensitive strain will come as first. So when we do a indirect LPA or LCDST from the pure culture, you will obviously get in most of the cases the susceptibility pattern of the drug sensitive strain. That is the limitations. If the culture has done could have done on solid culture, we can get the two types of colonies morphologies, and we can get both drug sensitive and drug resistance. And my another point is that now in first and third episode, the LCDST was done obviously from the liquid culture. Now indirect LPA could have been done from that, so the report could be obtained much earlier. That is my point to say.
Yes, and the same. Thank you very much for raising this issue. You see, even today, the technical guidelines to microbiologists is that along with the liquid culture, you must do the solid culture. It again helps in the NTM also. But unfortunately, as we observe, most of the laboratories in the country, they have stopped doing the solid culture, which I feel CDD needs to review this. Like these kind of cases, or even for NTMs, they have to do the solid culture. And many of the laboratories, they do not have this facility. So I think you raised this question at the right juncture, and we request CDD to look into it, please.
Yeah, I have a question for you. You said that pyrazinamide is responsible for persisters, but under the program, are you releasing report for pyrazinamide? Because we are not getting pyrazinamide for a long time now.
Actually, ma'am, we have conducted a study, yet not published, but it is published in a state microcon. That is that we have retrospectively checked the details of the pyrazinamide resistance. We have gone through the all the strain and sample which have come with pyrazinamide resistance, and we have found that in most of the pyrazinamide resistance, we found there are two, three, or more multiple episodes by following the niches. So we predict that if there is a baseline pyrazinamide resistance, there could be persistent. And this case, in terms of after 1 or 2 years, this case might come back in the society or maybe in the clinic as due to the resistance of pyrazinamide. It is our observation, yet not published, but we have published in our Microcon 2025 state chapter.
No, so my question is, why are we not getting pyrazinamide resistance reports from the lab? Why is it not being done?
Yes, ma'am. Yes, ma'am. The algorithm says that when you get a MTB detected by NAT, now you have to go for first line and second line. We don't have any provision of pyrazinamide liquid culture. Pyrazinamide liquid culture is a phenotypic test. So unless you have that algorithm made in the or incorporated in the NTP, so it is not always a provision of pyrazinamide phenotypic test. But as for DSTB, we don't have. We have to limit it to our first line and second line, and we that in that way we actually missing the pyrazinamide resistance.
Yes, in this context, among the drugs, resistance cases, I think very important to do and to report paragenamide resistance. And this issue we have been raising for quite a long time, especially when the shorter regimen was launched. And PZ resistance is a contraindication to start the shorter oral, the 9 to 11 months of regime. But still we find that the all in extended DST, everything is being done, but not Z resistance, and we really have to request separately to do the pyrazinamide resistance. I know that there are issues of being acidic media is inhibiting this pyrazinamide, and we require the other methods. But still, it should be an important part of the reporting of the DST in cases of drift resistance cases.
Sir, another point I agree that even detecting at MTBC, that is complex, so it includes bovis also, and bovis is intrinsically resistant to pyrazinamide. So there is a published data in Madhya Pradesh where they found actually nearly 30% of pyrazinamide resistance in DSTB cases. So, sir, that could be another possibility, that pyrazinamide resistance in Mycobacterium bovis, which we reflected in case of MTBC.
I think in this forum we have raised this issue of pyrazinoate resistance, and we request TDD to take note of this so that we can have a revisit about this ZDST being available. That is my request.
Yeah, Dr. Jyoti, you have a question?
Just, I just want to answer to what Sir just asked, why the DSC is not being done. As in the algorithm, it has to be done for RIF and INH resistant cases, but of late, ma'am, BD has taken the entire drugs from the labs because there was some QC issues. So that's why this is the reason that labs are not able to do PZA DST right now.
Thank you, Dr. Jyoti. Are there any other questions or comments? I have a comment to make, like the case that Dr. Komal just has taken is from a medical college, and a case reaches a medical college only when it is gone out of hand, when it's already spoiled by the private practitioners or it's not taken care in the field. So these medical colleges are the nodal DRTB center, but if these cases report to district TB officers in time, and if they are given right regime in the right doses, and if they are properly monitored, maybe this situation may not arise. So I think there is a need for sensitizing our private practitioners. There is a need for our district TB officers to take onus of all the DRTB that is diagnosed in their district. If everybody is able to do that, I think such kind of cases will come down. So that's my comment on this case. Yes, there's a hand raised, Dr. Paresh Nath.
So good afternoon to everybody. So actually, my submission is that in the 21 and 2021 PMDT guideline, revised guideline, there is clearly it is notified that if rifampicin is coming resistant, then we should go for the CDST for also for PZA, for pyrazinamide. So it is in the guideline. It is in the algorithm.
Yes, sure.
So we should do it.
Yeah, for sure. That's what I was raising, that it's a part of our national algorithm. So there is no reason not to do it unless we have a official documentation that it is not required and
it is there, sir.
Should be done.
It is clearly mentioned, sir.
Yes, correct.
Yes, sir. Even if INACV resistance is detected, also we should go for the pyrazinamide. It is there also.
True, because one of the drugs in the regime for H resistance, out of the 4 drugs, one of them is pyrazinamide. So it has to be done.
Right. Thank you. So, Dr. Singla, what is your take-home message for this case?
Take-home message is that whenever we are faced with a patient, we must ensure, like in this case, the very irrational regime was given. Depending on the patient, the DST profile, and the past history of ATT, we must use the appropriate regime, appropriate dosages, and for appropriate duration, and ensure the compliance. I think 90% of the problems will be solved. Otherwise, we'll end up in such situations, and then we have augmentation of resistance, which never stops. So the basic thing is that must use the appropriate regime with dosages and complete till the end and ensure that. Thank you.
Thank you. And I'd just like to add that we need to train our health workers for recognizing the comorbidities and ADRs at the earliest and refer the patient to higher centers as needed. Thank you. So if there are no comments, we come to end of our clinic. I would request Dr. Ashok Bharadwaj, sir, who is the chairperson for the NTF, to.
Thank you, madam. Thank you. So I was in Uttarakhand, Dehradun. So there was a training. So I came here in medical college. So I am privileged to be associated with this national TV, difficult to treat TB clinic. So I always try that maximum people should join it, but somehow the attendance is short. So it was an interesting case. So I thank everybody for joining today, and I personally thank Dr. Neeta and Dr. Rupak for taking this from time together, and regularly we are having this clinic. So I am also trying that the peripheral level worker, wherever I go, I ask them that you must join this clinic. At least you will understand something about tuberculosis and the program. So thank you very much. Thank you for giving me chance. Thank you, madam.
Thank you. Thank you for joining us.
Mm.
And we request you to give your feedback. Thank you, Dr. Komal, Dr. Tanvi, and everybody who has joined us. Thank you.
Thank you, ma'am.